Hello, my name is Dr. Sam Chachua. I'm an MD from Melbourne, Australia, and the inventor of Induced Remission therapy. The object of this video is to give you some idea of the background and technology involved with IRT, Induced Remission therapy, and to allow you to make intelligent decisions when it comes to therapies that could be life-saving. I first started in this at a very young age. My research began around age 13. My father was diagnosed with multiple myeloma, which was a bone marrow cancer that literally exploded every bone in his body. And I, as a kid, hit all the libraries trying to find something that could help him. It was almost amazing and unintelligible to me that with all of today's modern technology, with all the scientific wizardry that we see about us, a disease that's been around as long as cancer still manages to be the greatest plague that we have. Still manages to escape every available therapy, still manages to laugh and spit at us as it takes us down a road of suffering, both for the patient and for his loved ones. Now, how could a technology so advanced as ours is today be failing us in something so important? I mean, how could we be landing men on the moon and still not be able to cure a very basic disease? And I thought the answer had to lie in something. There must have existed something. The years that followed, my family and I tried virtually every available therapy that we could read about, find out about. Pretty much no avail. And although the seeds of induced remission therapy, the origins, began in this time period, at a very young age I entered my first laboratory at the Cancer Institute, the Clinical Oncology Society of Australia. In 1981, actually received my first publication, my first presentation of the first bit of work I did at age 18, 19. So back then I began looking for answers, looking for clues. And back then I did see some pointers to what later developed to be IRT. It was too late to help my father, but hopefully it'll be able to help many of you for years to come. When my data was actually at a point where I could present and make firm, substantiated claims about efficacy of this technology, I was amazed by the deafness of all the major medical groups in my native country. I was amazed by the rejection and the disbelief that I was hounded by there. Induced remission therapy is a very simple technology to demonstrate, both in theory and in practice, clinically, and in a laboratory setting. There's really no excuse to disbelieve a technology that can be demonstrated in less than 2 hours in any lab. And yet, there was a lack of desire to even investigate it. As I said, the silence in Australia was deafening. So, back in 1992, I decided to explore greener pastures. I was invited to lecture in America. And it was quite a refreshing experience. American audiences are very different to Australian audiences. I presented cases treated by induced remission therapy and had responses, and the crowd was very, very motivated, applause and standing ovations. And I felt really good. I thought, well, you know, I'd finally achieved what it was I needed to achieve. Of course, this was the first time I'd presented in a public forum, something that most doctors shy away from. But I'd come to a point where I had developed a technology and a therapy that I had been promoting for 10 odd years or more or less without any response from the medical profession. And I thought then, and I think much more so now, that if a curative technology does exist, perhaps it's the right of the patient to know about it, particularly when the doctors refuse to hear about it. It's delighted me in recent times that doctors are starting at last to listen. But getting back to my first presentation on US soil, my standing ovation after having presented case after case cured by this technique, cured of cancer, cured of, or at least helped in a major way of AIDS, arthritis, and multiple other diseases. Following my standing ovation, I had announced in the lecture that my cure rate was only 20% cure rate, between 10 to 20%, on patients who were considered very terminal or incurable, who had failed all other therapies. But I was no God. I could not cure 100% of people who could come to me. Following my lecture, during the question-answer period, somebody from the audience stood up and said to me, excuse me, Dr. Sam, you only cure 10 to 20% of cases? And I said, yeah, I'm afraid so. Currently, technology limits me to that. He said, well, that's pretty pathetic, isn't it? I can cure 100%. And I said, sorry? He goes, yeah, I can cure 100%. And with that, the audience all turned to him. And I said, well, how do you cure your 100%? And he said, aloe vera. I cure 100% of my cases using pure aloe vera. And then that guy got a standing ovation from my audience. And it's strange, because I couldn't really decide what was worse, being ignored by the Australian audiences or being accepted by an audience of fools who applauded the aloe vera guy. There had to be a happy medium somewhere. You couldn't just go to a public forum made for people who believe that the Pleiadians are coming and that UFOs are going to rescue us before the weekend, and hope to gain acceptance. At the same time, the medical profession wasn't listening, and basically you had to forge through on both fronts, which is what I'm doing right now. I'm presenting this data for people, for the public, so in a way that they can understand it, in a way they can speak to their doctor about it. At the same time, we're forging through with trials in major respected university and medical institutes. So hopefully we'll have the outcome of both of these things in unity, so that the work can be announced at the time that it can be accepted. It's worth noting that right now I've also have an offer for 100 patients to be treated of cancer and AIDS free of charge. The therapy is actually an expensive therapy, but I'm offering to treat 100 patients free of charge, provided that a registered institute or medical center can monitor and observe their response. And I'm also offering $10,000 to whichever institute is willing to do that, to prove me right or prove me wrong, provided it's a respected institute on US soil. One other thing that I will ask of the viewing audience is that they exercise great caution while choosing therapies, or while listening to beliefs, before believing claims. It is very important that you take the time to evaluate them, you take the time to discuss them with your doctor and investigate the validity of such claims. It's very important that your doctor gets in touch with whoever it is who's about to initiate whatever therapy. It is important that you avoid the fakes and the frauds that do exist about us. I myself have managed to start a cottage industry of people who claim to be using vaccines like mine or which are mine. I myself have gone through the pain of wanting to believe that ozone can cure cancer, or that vitamin C can cure cancer, or that diets can cure cancer. And without saying that these things are invalid as therapeutic options, I'm sure they do have their value, but they're by no means the cure-alls that they claim to be. You need to have a good system of evaluation, and you need to motivate your government or whatever ruling bodies to have every therapy investigated in a manner whereby you can know whether or not there is any validity to it. Returning back to the main point, I'd like now to discuss with you some of the key features of induced remission therapy. As a kid, searching through the literature trying to find something that could help my dad, I was drawn towards immunology and immunotherapy more than anything else. Well, I'd seen chemotherapy and I'd seen the effects it was having, and I really didn't want to add to that misery. I'd seen my father losing his hair, vomiting, feeling weak within days of having it administered, and I'm sure many people are familiar with the side effects of that. So immunotherapy held the greatest hope. It really held good hope and good promise. And yet, of all the cancer therapies, it's the one that's delivered the least over the past 100 years. There's a reason for that. There's a reason for that. And some of these reasons are actually well known. One reason that immunotherapy in medicine, in cancer in particular, fails so miserably, whereas immunotherapy in infectious disease such as measles, mumps, the flu, polio, tends to work so brilliantly, is that there's something missing here. There's something different. When we're trying to vaccinate against infectious disease, we're vaccinating against something that does not exist in the patient's body. When we're trying to vaccinate against cancer, we're trying to vaccinate to destroy a disease that already exists there. Now, there's a huge difference between these two events. If you go to your doctor and you've got the measles, he doesn't give you a measles vaccine. Vaccines are only really useful in preventing the disease, not in treating it once it's already there. If you go to your doctor with the flu, he doesn't give you a flu shot. The flu shot is only useful to prevent you from catching the flu. So here in cancer, we're faced with a big mass of disease that the body can't fight. And we're trying to vaccinate the body so it rejects it. And it's an entirely different scenario to any other vaccine. There are other problems with vaccines in cancer. And one of the ones that's most recognized and most written about is a factor of threshold inhibition. Most immunology texts will tell you there exists a phenomenon known as threshold inhibition, whereby if a disease is above a certain size in the patient's body, the patient will refuse to attack it. Because, assumingly, if the patient does attack a mass that large, it would have very deleterious effects on the body. But basically what happens is, if a mass achieves a certain size in the patient's body, much of the patient's immune response sees it as part of the patient and refuses to attack it. Now, what's the point of me vaccinating against this big ball of cancer if this immune system refuses to recognize it, refuses to attack it? What's the point of me increasing it 1,000-fold? There is no point. If the immune system will not attack this, simply amplifying an immune response that refuses to attack cancer will give you a bigger immune response that refuses to attack cancer. The answer isn't in amplification, it's in modulation. You have to change the immune response. But let's stay with the problem of threshold inhibition for a moment. Doctors recognize this. Immunologists recognize this. They know that if they stimulate the immune response against this cancer and the cancer is above threshold inhibition, that the body won't attack it. So what they have to do is debulk the cancer. Debulk it by surgery, chemotherapy, or radiation. Now, if you debulk the cancer by chemotherapy or radiation, what you're actually doing is killing the outer layers of the cancer. It's like peeling an onion. The thing is, inside here, the cancer cells are different to the cancer cells outside. And we know that if we treat something with chemotherapy, if we treat cancer with chemotherapy, that will reduce some cancer mass, but the residual cancer cells will be resistant to the chemo. We also know that there may be structural changes stimulated by the chemotherapy in the cancer itself. So what's the point of immunizing against the initial presentation of cancer if we're going to modify the presentation by the therapy that debulks it? And I'll explain that again in a moment. Again, what's the point of amplifying this response if this response refuses to see the cancer because it's above a certain size? There is no point. So we reduce the cancer to a size that will be below the threshold inhibition, hopefully. But when we do that, we change the structure of the cancer cell. So what relevance is there to the vaccine that we've manufactured? And this is something that I'll need to sketch out for you to see. If we take a cancer out from the peripheral layers, perhaps we can schematically represent it like a little cell with antennas. If we take a cancer out from the deep layers, or after it's been debulked, see, debulking by chemotherapy or radiotherapy will kill off the superficial cells and will either release the deep cells or mutate them so that they have a different appearance. Now, what usually happens in conventional immunotherapy is that there's a lack of anticipation and it's a static application. What that means is that when you're diagnosed, the doctor will take a piece of your cancer, a biopsy, send it off to the immunologist. The immunologist will isolate all of these cancer cells with antenna, and the immunologist will raise a vaccine that will stimulate the immune system to create antibodies and cells which recognize these antennae. And they recognize them by immunoglobulins or by specific receptors that will make the cell, the lymphocyte or the white blood cell, specifically attached to the antenna and destroy the cell. In other words, the cell marker taken at initial biopsy is made into a vaccine or used in the making of the vaccines. And the body responds to the cell markers of the initial biopsy. The initial biopsy is of no use in treatment of cancer prior to debulking, because if you use this vaccine prior to debulking, you're up against the threshold inhibition. If you debulk the cancer and then use this vaccine, you've got these immune cells that you've stimulated, but they're facing these new cancer cells that bear absolutely no resemblance to the old ones that they were raised against. In other words, you've got a catch, well, it's not quite a catch-22, but it's close enough. The vaccine will only bear relevance to this cell when this cell exists. But this cell exists when there's threshold inhibition. Get rid of the threshold inhibition by making the cancer smaller using chemotherapy or radiotherapy, and you've generated new cancer cells. And these new cancer cells bear no resemblance whatsoever to the vaccine and the effect of the vaccine that you raised initially. This, in a nutshell, explains why immunotherapy has failed so miserably until now. And now we'll look at ways of actually making immunotherapy, we'll look at ways of making the immunotherapy work better. So to recap, one of the first lessons I learned in trying to evaluate immunotherapy was that there are some big differences between vaccinating against measles or mumps and vaccinating against cancer. Not only in the fact that infectious disease vaccination tends to be successful and cancer tends to fail, but the reasons behind it became pretty obvious. In one instance, you're trying prevention versus treatment. When you're dealing with infectious diseases, you're trying to prevent them, not treat them by the use of vaccines. When you're dealing with cancer, you're trying to cure cancer that already exists by use of a vaccine. Secondly, there's a very real risk that a vaccine made of cancer cells to stimulate the immune response may amplify the inappropriate immune response incapable of curing cancer. In other words, if the cancer looks one way, you take a piece of it out, make a vaccine out from that piece, inject it back into the patient. Now what? The patient has his own cancer that he had to begin with, plus more cancer junk that you're injecting into his system. The body is already threshold inhibited by the bulk of cancer in his body, and now he's got even more bulk. And worse yet, this looks very much like this. So you're just feeding the inappropriate response of the patient. The third problem is, if you try and overcome this by making the cancer smaller so that the patient is not so overwhelmed by the sheer bulk of it, most of the therapies that will debulk the cancer will change the appearance of the cancer. So there's no point vaccinating with the initial biopsy, vaccines made from the initial biopsy, because those vaccines will no longer bear any resemblance or bear significant resemblance to the cancer as it exists after the debulking procedure. The upshot of this is that one of the first things I began looking at is trying to overcome the threshold inhibition phenomena which was the bane of immunology and immunotherapy to this day, which was back then and which is to this day. So we will now discuss some of the methods with which to do this. So we've seen that in animal experiments, if the cancer is small, the immune system of the animal can sometimes handle it and eliminate it. But if the cancer is of a large enough size, it inhibits the immune response, threshold inhibition. Ways to overcome this have to be found in order to be able to reject the cancer by an immune procedure. Now, conventionally we debulk, we try and shrink the cancer. We've seen that that doesn't work if the debulking procedure changes the appearance of the cancer. We have to find a way of either debulking the cancer in a way that it no longer, the debulking procedure no longer changes the appearance of the cancer so that our initial vaccine bears some resemblance, or we need to vaccinate in anticipation of the new cell type, or we need to raise a whole new immune response and modify the appearance of the cancer. But I'm raising points that we'll go into later. Let me mention the first idea I came up with, which was if the immune system is being inhibited by cancer, perhaps somewhere in the body there is a place where the immune system isn't being inhibited by the cancer. And to search for this place, I looked for places in the human body or in animal bodies that were hardly ever affected by the cancer process, or in patients or animals with the cancer where the cancer was extensive throughout their body. I would look and see where isn't there cancer in this body. From doing significant literature searches, it became evident that two places fitted that bill, at least two. One was the spleen, and the other was the small intestine. The spleen had already had significant amounts of work done relating to its supposed cancer resistance. And the spleen is by no means as immune to cancer as the small intestine is. So I set about looking at the immune system in the small intestine, a group of cells known as Peyer's patches. The lymph aggregates are known as Peyer's patches. I extracted out lymphocytes from Peyer's patches. At age 18, I was at the Peter MacCallum Cancer Institute and the Clinical Sciences building. So I was at two very prestigious research institutes in Melbourne doing this work. And I managed to isolate some very powerful immunological responses from the small intestine. And that work was published in the Clinical Oncology Society of Australia, COSA Pracy, and presented at this COSA. I was the youngest ever presenter of an original paper at COSA. Interesting point to demonstrate the efficacy. It would take 50,000 white blood cells, more or less, 2 or 3 days under maximum immune stimulation by interferon interleukin to kill a handful of cancer cells. And with Peyer's patch lymphocytes, you could kill one cancer cell in 1 hour using one Peyer's patch lymphocyte. And there was evidence that you could destroy up to 400 cancer cells in a similar period of time, again using just one Peyer's patch lymphocyte. So here we have a way of using a system resistant to the threshold inhibition phenomena. It turns out that the Peyer's patch lymphocytes did not circulate, so they weren't needing to be confronted by the cancer in huge mass quantities. So that may be one way by which they escaped the threshold inhibition phenomena. The other thing is you would expect the small intestine's lymphocytes to be much more active than ordinary ones, because that's one point of contact of incoming food, incoming toxins, incoming allergens. You would expect the system to be able to neutralize those effectively and efficiently. I presented at this prestigious meeting, the COSA meeting, and I really thought that it would gain create some interest and gain some acceptance. And that was my first lesson in growing up in medical research. My work was totally ignored. I stood there, wallflower, next to my Peyer's patch lymphocytes, my presentation, and perhaps, this is a biased opinion, but perhaps one of the most important papers being presented at the time was overlooked in favor of other papers about theoreticals or about diagnostic techniques. This was a system that could have been used in therapy. It led to the development of another idea, and it was an idea which is at least presented in part at the same meeting. There aren't only organs resistant to cancer. There are also organisms resistant to diseases. There are many organisms resistant to diseases that haunt and plague mankind. And one of those is AIDS. The same way that there are organs which resist cancer process, there are animals that resist the AIDS process. And I only mention this as a mention right now because it's historically in time with the COSA presentation. If horses are resistant to AIDS, why not use a horse's immune system in the fight of the AIDS disease? 100 years ago, we used horses to fight rabies, polio, smallpox, all the viruses and bacteria that we couldn't fight against then. And the theory or the idea was raised back then, why not use a resistant immune system, the same way as I was proposing to use pious patches, a resistant immune system of the body against cancer, why not use the resistant immune system of another animal against AIDS and facilitate a cure for perhaps the most deadly infective plague of our time? Why not start using a therapy that was used 100 years ago before we had all of our pharmaceuticals, antibiotics, a therapy which proved effective then against the plagues of those generations? A therapy which could give real hope now where absolutely no hope exists. So what we've seen basically, I mentioned about AIDS and about horse serum extracts, and I'll go into a lot more detail about that, but I don't want to distract from the main issue that I'm discussing, which is how to overcome the phenomenon of threshold inhibition. To overcome the phenomenon of threshold inhibition, you need to either find a system that's resistant to it, which we just discussed, finding pious patches, or use of an organism that's resistant to it, like a horse or other animal. What you're doing now is a process of passive vaccination. In other words, it doesn't matter if your immune system can see it or not, or can fight it or not, you're going to use an immune system from another animal. So it's passive vaccines. And even that had a problem. The problem here is this. We know that we can raise passive vaccines against virtually every virus or every bacteria that we know. We can create animal passive vaccines against many diseases, and that, again, like I said, was the preferred method of treatment 100 years ago. We could prevent polio, smallpox, measles, mumps outbreaks by vaccinating people with passive vaccines, and we could actually treat them once they had it using passive vaccines, because it comes from an outside source, it's independent of your body. You're not exposed to threshold inhibition. But if you try and use a passive vaccine against cancer, whereby the horse is vaccinated with a human leukemia cell, for example, and then asked to destroy specifically the leukemia cell, that's not going to happen. What you find is that the horse reacts strongly against all human cells, and that even though he's been vaccinated against the leukemia, he will destroy any and every human cell that he's exposed to. And that was the first clue to the cancer paradox. And it was a clue that wouldn't ring in my head for many years till I was mature enough to actually work it out. But I was stuck in what I call the macho war mindset of cancer therapy. And the macho mindset is, there's an enemy, you have to go and destroy it. So passive vaccines weren't doing the trick. We had to destroy it using something else. And again, our main obstruction was a threshold inhibition phenomena. Well, get back to what I said before. Most of cancer therapy is static. In other words, somebody shows up, this is their cancer, this is what they're going to have, bang, bang, bang. We run out of treatment, and the person dies. because we've made no plans for the future. Once we've used up our bag of tricks, there are no more tricks. What I propose then to do is to try anticipatory technology, or to put a dynamic flow into cancer diagnosis and therapy, rather than just have it a static, one hit, one miss deal. So the process of anticipation is how I like to refer to my second major technique of bypassing the threshold inhibition phenomena. All good things come to those who wait. So anticipation essentially says, I know that if the cancer looks like this, and inside it looks like that, if I'm going to treat this cancer to debulk it, I know I'm going to peel away the outer layers and be left with these inner cells, or these altered cells, these cells which have been altered by the debulking therapy. So instead of taking my biopsy at the start and making a therapy which will treat cancer cells with antenna, I'm going to either match what I anticipate will come out, or I'll take my biopsy at the end and vaccinate against these spiky cells from the middle. Now, the best of both worlds is to be able to anticipate precisely the changes that I'm going to make, and that is doable with current laboratory practice and with current cell line banks. You can anticipate the changes that you're going to make, and having made them, you vaccinate the patient against them. So what we're describing here is a process of dynamic flow. It's a process where, okay, I'm going to take cancer cell A and I'm going to change it by my debulking therapy to cancer cell type B. So when I reach cell type B, instead of panicking that I've no longer got a vaccine that will work against it, dynamic flow means I'll take cell type B and I'll make a vaccine against that. Now, this will be good because cell type B is one which hopefully after debulking will exist sub-threshold limits. But it's not so good in that if I do a process of dynamic flow where as the changes happen, I modify my vaccines with the cellular changes, I'm always playing catch-up with the disease. It's far better to anticipate the changes before they happen, vaccinate against them before you initiate them, and then as the cells arise, your immune system is ready to gobble them up one by one. This is a process of anticipation, dynamic anticipation. If I know that I'm going to treat a cancer patient with adriamycin, and I know the changes that adriamycin is going to do to the cancer patient's cells, and I know the cells that are going to survive the chemotherapeutic treatment, then I'll vaccinate against those before I even give the adriamycin. Now, I'm vaccinating against a cell type that does not yet exist in the body. I'm vaccinating at something that the therapy is going to create before I even give the therapy. The body gets 2 or 3 weeks to build up its immune response without being constrained by the threshold inhibition. I then administer the therapy and cause the genesis of the cells that the body has been vaccinated against, so that the adriamycin kills off all the cells it can kill, and that the immune system kills off all the leftover cells that the adriamycin didn't kill. Anticipatory therapy is the second way of bypassing threshold inhibition. And there's a third one. Actually, there's probably quite a few, but there's only 3 that I've applied. And that's called tagging therapy. And tagging therapy is where you take the cancer, which is essentially an invisible object to your body's immune system, and you stick something on that cancer to make it highly visible. And tagging therapy, more than any of the others, was born of an intensive study of spontaneous remission, a phenomena whereby disease which would ordinarily be terminal suddenly, magically, miraculously disappears, sometimes in days, independent of what therapy the person was doing. Spontaneous remission can occur in 1 in several thousand, from 1 in 2,000 up to 1 in 80,000, depending on the type of cancer and type of disease, and is known to occur in virtually all diseases, possibly with the exception of genetic diseases. Spontaneous remission almost always follows an infection of some form. And in the old days, people observed that Streptococcus pyogenes could cause erysipelas, a skin infection, and that could often lead to a reduction in tumor mass and a cure of the patient. Even 300 years ago, Dr. Didot noted that syphilis, the incidence of syphilis could restrict the incidence of cancer, and he actually treated patients who had cancer with syphilis. People noticed that malaria, an acute attack of malaria, could cure cancer. Yet oddly enough, chronic malaria and chronic syphilis can actually cause cancer. And this is a second part of the cancer paradox, which we will be approaching later in the piece. And for the record, I've never used syphilis nor malaria, nor do I ever intend to use syphilis or malaria in the treatment of cancer. But the idea is there, that infections can somehow cause cancer to go away. There's been cases of leukemia and lymphoma which have gone into remission after measles and mumps, which have had sustained, extended remissions after measles and mumps episodes. There's been cases even where animal viruses have caused human cancers to go into remission, the most famous of these being the Newcastle virus. So we're in a position now where we know that cancer is not an incurable disease. There are phenomena of reasonably regular occurrences, rare as they may be, they're still regular, where cancer magically disappears. And that lets us know that it's not an unbeatable foe. So a third technique to bypass the threshold inhibition phenomena is tagging. And as I mentioned, it's based on spontaneous remission. So how do the two things happen, and what exactly is tagging? Again, let's try and understand the spontaneous remission process. There are certain infections which can cause the curing of cancer. They have been heavily reported in the medical literature. But whenever the effects have been, whenever people have tried to duplicate the effects of these infections, they failed. They've isolated certain parts of the infections and tried to recreate them. For example, hypothermia, the popular therapy for cancer and many other diseases, well, a few other diseases now, is derived from spontaneous remission infections. Some scientists thought, well, what must be happening is that the bacteria or viruses are inducing a very high fever in the patient, and the fever is having the curative effect on the patient. So we grab a patient, stick him in a microwave oven, and hope that the cancer goes away. And usually it doesn't. So to try and understand this, we know that certain infections can cause the remission. We know also that doctors have said that, well, maybe the infection somehow stimulates the immune system, gets it really angry, and then the immune system then, angry, goes after the cancer and destroys it. Well, we have had many doctors who have taken the immune system white blood cells from patients who are having a remission or who've just had a remission and injected them into other people who are sick and dying of cancer with absolutely no response. So duplicate this in experimental terms. Here's an organism, let's say a Staphylococcus or a Streptococcus pyogenes, such as those associated with erysipelas. Incidentally, Streptococcus pyogenes and erysipelas gave rise to a vaccine called Coley's toxins almost 200 years ago. So the concept of using spontaneous remission to indicate an effective therapy is not entirely new. Anyway, we'll take an organism and we'll add to it cancer cells. And a lot of people say, well, maybe the organism directly infects and kills the cancer cells. But if you put these two things in a test tube, you'll end up with live organisms and live cancer cells. In other words, they can tend to coexist happily with each other, at least for a short period of time. But, they say, the immune system has been angered by the organisms. Therefore, it's the immune system that kills the cancer. So you go to a test tube, you add the white blood cells of the patient or animal who just had that infection to cancer cells. And you end up with live white blood cells and live cancer cells. The immune system will not attack or kill the cancer in this situation to any significant degree. However, in case number 3, where you add the organism plus the immune system plus the cancer, you end up with largely dead organism and dead cancer. Well, definitely dead cancer. And what seems to be indicated here is that in this scenario, you need all three components. The immune system alone and the infection alone are unlikely to cause massive destruction of the cancer. The two need to interact together to attack the cancer. So I also found that extracts of the organism were capable of eliciting the same response. This seemed to indicate that somehow the organism was making the cancer visible to the immune system, or that organism extracts were. Furthermore, the larger part of the immune system that was reacting against this tagged complex of cancer, which is cancer tagged by bacterial or other components, was largely neutrophils, where the organism was a bacteria. And neutrophils are known to attack bacteria. So if neutrophils are now attacking cancer, something must have happened to make the cancer look like a bacteria. And the tagging component, the tagging theory, says that certain bacteria and bacterial extracts, certain viruses, certain fungi and their extracts, yeasts, etc., certain microorganisms and their extracts are capable of attaching to cancer cells and altering the appearance of the cancer cell, so to the immune system it looks like we're fighting a bug. And if the immune system thinks it's fighting a bug, it can mount a much stronger response, a much more determined response, and often a curative response. So that might be a system whereby we can explain how cancer gets cured by this natural spontaneous remission phenomena. Cancer, which is sensitive to infectious agents, in that conventional thinking tells us that cancer cells have very poor immune response against infections, and that cancer masses have a center which is anaerobic that bugs love to go and live inside. The flip side of it is we know that cancer does not attract an immunological response. So if the bug is going to go anywhere in the body, where is the one place it's going to be safe from the immune system? The cancer. If the organism expresses its antigens, expresses its proteins, or saturates the cancer cell with its own structures, then what we have is a system where the cancer, which was previously immunologically invisible, becomes infected by, let's say, a bacteria. And this bacteria starts producing proteins and components which saturate the cancer mass. Now, when the cancer mass is totally marked like that with bacterial extracts and bacteria, the immune system, which was formerly sitting here minding its own business, suddenly sees a ton of bugs, really does get angry, and can go after it and destroy it. Much more importantly, most of our immune system is designed to fight bacteria and infections. Less than 1% is designed to fight cancer cells. So if you change the cancer mass to make it look like something the immune system would like to fight, you stand a much better chance of eliminating the disease. And if, as I told you before, you need to stimulate 50,000 of these white blood cells to find one or two which are going to attack cancer, the proportions are now totally different. Almost all of these cells, or the large bulk of our immune system, can fight bacteria, can fight microorganisms. And because of this, the threshold inhibition phenomena is no longer active. I don't use living bacteria, I don't use living bacteria to infect cancer cells or cancer tissue. I use bacterial proteins, which means that I can really control how much of this cancer gets saturated for any period of time. And this technology enables removal of the cancer mass in stages, in degrees, or as a large event if the patient is capable of supporting and maintaining such a reaction. So to bypass the inhibition phenomena, to try and duplicate miracles, and to try and initiate cures in terminal hopeless cases, we can fall on resistant organisms or resistant organs. We need to change the way that we think about diagnosis and therapy, instead of being static, stuck in one position, we need to be able to see ahead, peek into the future, anticipate the changes. We need to be able to tag, modulate, make the disease that you can't fight look like something you can fight. If you make the cancer look like a cold or a flu by sticking cold or flu extracts all around it, the body will get rid of it in 2 or 3 days or in a week or two, the same as it would process a cold or a flu, or at least it will diminish it significantly. So these are the processes on which induced remission therapy is based. Now, there's something to say about how it's advanced since then, and I want to give you a little bit of that story before we move on to cases and proofs. When I tried to isolate a range of organisms, bacteria, viruses, fungi, yeasts, whatever, that had somehow triggered a remission phenomena in a patient, I first set out to build a central registry whereby anybody who was having remission or healing could send in biopsies or tissue samples, clinical data, so we could isolate what organism was helping that person get better. And the flip side was also true. If there are organisms that can mark cancer cells or can antagonize them, can destroy them, there are those also which aggravate the cancer process. So people who are deteriorating could also send in, or their doctors could send in samples, and we could see organisms which were having a beneficial effect that we could support or introduce into a system, or organisms that were having a harmful effect that we would seek then to neutralize or eliminate. And that idea didn't get much support. The center was established, but there was never any support. So I set about trying to investigate in the laboratory or develop a system, devise a mechanism by which I could see and anticipate which organisms could mark cancer cells or could selectively infect them or could selectively destroy them. And I labeled these nemesis organisms. And I set about to try and find things that would specifically infect cancer cells in a test tube or in a bottle. And I started out thinking, well, if I get a cancer cell from leukemia, for example, from white blood cells, maybe viruses that infect white blood cells will infect leukemia cells specifically. And I tried that, and yes, they did. But I was surprised to find that the same viruses also infected breast cancer, they also infected bowel cancer, they also infected virtually all types of cancer. In fact, I was surprised to find that in my search for organisms that could destroy cancer, that cancer seemed to be acting like a sponge. It didn't matter what organism I threw in the soup, cancer would absorb it, incorporate it, be destroyed in part by it, and then somehow synergize with it and continue growth. And when I was researching the literature, I found this to be true too. I found that organisms such as the feline panleukopenia virus had been used in the treatment of leukemia perhaps 40 years ago in 2 or 3 trials. People with leukemia, the leukemia would almost entirely disappear within a week or two, then reappear a few weeks later, very aggressive, and kill the person. So cancer seemed to have the ability to absorb whatever infection was thrown at it and somehow develop resistance to that infection and then return again. The ease with which I was able to tag cancer cells using living organisms in a test tube, led me to believe that maybe cancer cells already come tagged with something in the real living situation. I mean, if just about every infection I threw at it would infect it, then maybe cancer cells already come with their own bugs in situ. And I was delighted to come across the work of a Dr. Alan Cantwell, who was a dermatologist and a genius in this field. And he, in biopsy after biopsy of cancer and AIDS patients, was able to demonstrate localized areas of bacteria and yeast-like organisms. In other words, the cancer already came with its complement of bugs. And maybe, just maybe, these bugs were even causing the cancer. So, even if they didn't, Even if these bugs had nothing to do with the cancer whatsoever, they were there. And if our immune system can't recognize the cancer and attack it, maybe it could recognize those bacterial organisms and attack them. So now we had a way of targeting cancer. The data eventually led to the completion of the cancer paradox picture. We have infections that can cause cancer. We have infections that can cure cancer. We have a disease that the immune system refuses to fight no matter how powerfully active it is. Maybe the immune system doesn't want to fight it. We have a system where we have to trick either the cancer or the body in order to mount a curative response. And that all began to gel for me in finally understanding the true cause, the true significance, and the true reason behind the cancer process. The cancer paradox is a term I give one of the biggest mysteries of cancer and the failure of cancer therapy, which could help explain the failure of cancer therapy. And it was something that I couldn't see through or understand for the longest time. I've already mentioned some of the reasons that I suspected there was something mysterious. I've alluded to the cancer paradox in the past in this video. There are certain observations that just do not gel with cancer. When somebody is immunosuppressed, cancer cells, or rather cancers, tend to increase in incidence, but not the common ones, just the rare ones, often the immune system ones. You would expect that if cancer was taking advantage of a weakened immune system, that the common ones would increase, but they don't. Cancer can occur in virtually every cell in the human body, and yet no other disease does that, and yet we consider cancer in the same ballpark as other diseases. There has never been a process of natural selection to lower the incidence of cancer in our society. If anything, it's increased 100-fold over the past century. Cancer cells are a mystery. There's a lot of things that do not make sense. And going back to simple models often helps us to understand things that are mysteries. One of the simplest models we have for cancer is a plant. A plant which, when infected with an organism named Agorabacterium tumefaciens, will give us crown gall. And crown gall is a cellular response by plants to enclose bacteria so that the bacteria does not spread and destroy the plant. And it's a cellular multiplication, an almost malignant cancer-like process whereby the plant will generate a huge number of cells to enclose the bacteria. And if we cut into that, much the same as if you cut into a cancer in a human being, the cancer tends to spread and metastasize. If you cut into a plant's crown gall, then what you'll find is the bacteria, the Agorabacterium tumefaciens, tends to escape from its cellular cage and spread throughout the plant and metastasize more or less. The cellular response follows it, and you end up with cancer metastases throughout the plant, and the plant dies. And here you see cancer actually serving an immunological process in the plant form. You see it actually conferring a survival trait or a survival characteristic to plants. And could that possibly have any relevance to the human disease process, to the human cancer? Could cancer actually be serving us some form of benefit? And that concept alone is horrible and horrendous to most people to even consider. And we'll go into further proofs that are supportive of this line of thinking. But perhaps it's also as important to go into reasoning as to why we are so resistant to looking at something of that nature as a possible key to understanding cancer and a key to understanding how to remove the disease process from our system. The key, or the main, or the culprit in our resistance as seeing cancer other than anything more than an evil enemy that needs to be destroyed, is the mindset and the belief system generated by the war on cancer. The war on cancer is more than just a fancy phrase that people use or that scientists use and politicians use. It's actually fueled the cancer industry for perhaps several generations now. if there is anything to deduce from the application of the terminology, if there's any conclusions to be made, well, we've lost the war. We've been losing the war dismally and just losing ground steadily for the past 100 to 300 years. Cancer and war are very emotive, and they're intertwined in ways that are incredible, not simply psychological. The chief method of therapy these days is chemotherapy, and chemotherapy was a technique developed in wartime situation, actually from the observation of an accident back in World War II where nerve canister containers in Italy were bombed by Allied forces, and seamen fell into the waters and were fished out by the Navy. Soldiers fell in and were fished out. And when they were fished out, they were found to have lowered white blood cell counts over the days they were observed. And what had happened was that the canisters of nerve gas or mustard gas, which had mixed with the water, was absorbed by some of the people and had served a powerful chemotherapeutic activity in immunosuppressing them. Doctor on base reasoned then, well, if this mixture can lower the white blood cell count, why not use it to lower white blood cell count in leukemics who have way too many white blood cells? And that was the birth of chemotherapy as we know it. So it was a therapy born in war. But it's a war that's been based on lies, as have been so many. One feature that does resemble war is the propaganda campaign. Barely a week goes by without us hearing about a new breakthrough that promises the end of cancer. Barely a week went by during the Vietnam War where the American public weren't promised an easy victory in sight, and yet they never come. And yet the promises come, but the results never do. There is a reason for thinking of cancer as a war. It gives doctors and patients the sensation that they're heroes or that they're fighting. It gives them the ability to accept and condone barbaric therapies which mutilate and which destroy at a person's body. And in a war situation, when you're considering the cancer as a vicious, evil enemy, it actually gives you a good feeling to think that you're poisoning it or burning it or cutting it. What better sensation could a patient feel than actually lashing back and striking back at his tormentor? And the doctor who's administering the poisons and who's doing the burning is in essence a hero himself. So we have heroes and villains clear-cut. We also have a situation where in a war setting the end justifies any means. In a war setting, what horrible suffering will a hero not expose himself to, will a hero not undergo in order to defeat the enemy? And in a war setting, the object is to win the war, not save the hostages. I guess in that sense, the cancer therapies do fit into a war-like analogy. And it's a war that stimulated inner wars. There are wars within wars. There's the aggressive conventional therapy, which sometimes work and usually causes incredible discomfort and harm. And there's the comfortable, non-aggressive alternative therapies which don't work. There may be some benefits to them, but they're outrightly rejected by the conventional people, and there's another war between alternative and conventional therapies. A war that could so easily be resolved were the alternative people to comply with demonstration of X-rays, blood tests to show whether something is efficacious or not, or were the conventional people open enough to observe, analyze, and actually unbiasedly conduct investigation of alternative technology. That perhaps be the easiest way to reject all the garbage and find what it is that actually works in alternative fields. And yet it's a war situation and nobody's really interested in any of that. Now, if cancer is our enemy, who've lost the war. But cancer is a paradox. There are reasons to believe that it's not an enemy. There are reasons to believe that it may be an integral response in our body against the real enemy. As I mentioned before, cancer can occur in virtually any cell in our body. As I've mentioned before, cancer therapies that aim at shrinking the cancer mass are not often successful. In fact, if we use aggressive chemotherapy and radiotherapy to shrink a cancer down, what we often find is that the cancer metastasizes more aggressively, goes to other sites. If you think back about the plant model, if that cancer was somehow enclosing a disease that would otherwise be lethal to our body, our shrinking the cancer mass without addressing the central disease or the central cause would do no more than aggravate the disease process and allow us to kill ourselves faster. Again, cancer as a helpful response is almost unimaginable. And yet one simple experiment demonstrates that. It may be. If you take a group of rats or laboratory animals and inject them with tetanus, they will die in agony within a few days or a few hours. If you take laboratory animals, allow them to develop cancer or induce a cancerous change in their bodies, and then inject them with tetanus, they won't die. In fact, they'll hardly feel a thing, because the tetanus will enter into the cancer mass and become encapsulated by the cancer mass until the body is able to mount a sufficiently effective immune response to remove it from the system. So here we see the body working hand in hand with the cancer mass, protecting the animal. Cancer may be a response that got out of hand, or it may be an integral response to something that just can't be handled by the body anymore. And to support that, we find that as the immune system gets weaker, as we have diseases or exposures that give you weakened immunological function, cancers tend to develop more commonly. And they often tend to develop more commonly in the immune system itself. Whether or not what I'm saying is correct, it does shed some light on one feature. If cancer is a response, an immune response, a restricting immune response that encapsulates, or if it's in any way a supportive response against whatever stimulus the body cannot deal with, whether it be radiation, pollution, organisms, we have a situation where removal of that response without removal of the cause will aggravate and accelerate the decline of the patient. We have a situation where the one disease, one cause theory no longer holds. What's the cause of malaria? Malaria. What's the cause of the flu? The flu virus. What's the cause of the measles? The measles virus. What's the cause of cancer? Well, smoking, radiation, pollution, stress, emotion, organisms. So we see that cancer is multiple causes. And the only way that the body can respond to multiple causes by the same form of malignant change, you can only get the same response out of multiple causes if the response is integral, if the response is ingrained in every cell. Cancer itself is not the disease. It's a response to something that the body perceives as deadly. And that something is what needs to be removed from the body. And as I said, that is my theory. Whether or not it's true, cancer exists, already tagged with organisms, already marked by organisms. We can apply the principles of induced remission therapy to anticipate changes, to target the disease, and to hit at a tagged disease to modify the immunological function so that we can obtain a curative response. And I'd like to now recap what I've said to you and actually demonstrate some proof. And it's very important that I do this at this stage because all you've heard is theory. And it's very important that whatever therapy you consider involving yourself with or you consider undertaking, it's very important that you allow yourself and your doctor the luxury of reviewing hard data such as that you're about to be shown right now. This first slide is to demonstrate that this work originated from data from research at very well-established institutes in Australia. You see the tumoricidal properties of Pious patch lymphocytes in buffalo rats bearing 5123 TC hepatoma and BALB-C mice bearing myeloma MOPC 315. Chechua S, that's me, that's a primary author. And the co-authors, you see, represent the very best cream of the crop in researchers in Melbourne at the time. And the centers, the Immunogenetics Research Unit at the Cancer Institute in Melbourne, and Department of Surgery, Biochemistry, University of Melbourne. So some very powerful heavy hitters were behind the very initial theory. And this is the landmark paper that, well, I call it a landmark paper again, quite biased. In my life, it's a landmark paper. It's the one that started everything, which showed that you could isolate lymphocytes from areas resistant to cancer and use them to treat the entire body. It's also what initiated the concept of the use of resistant organisms, such as horses and other animals, and that's what made me look at the use of that in the treatment of AIDS and other diseases. But this is just to establish credibility. Now, the main bulk of the research is based on the phenomenon of spontaneous remission. And we see here, for example, organisms inhabiting red blood cells. And these organisms represent malaria. Malaria, seen in the slide, is one of the most often reported organisms and infections which can result in a spontaneous remission. Now, as previously mentioned, as part of the paradox, acute malaria may result in a spontaneous remission, whereas chronic malaria may often cause lymphoma. In other words, cancer may be cured by an infection in its acute state, where the infection, as I've explained, marks the cancer and makes it appear to be something else. Or it can be caused by the same infection in chronic state if that infection depletes the immune system so much that a cancer has to be generated to encapsulate it and prevent it from killing the body. Here we see a trypanosoma, which is another parasite which has been linked with the curing of cancer in spontaneous remissions, also inhabiting a red blood cell. Now, I don't want to be injecting people with malaria and trypanosoma to achieve remissions. And as discussed, I attempted to identify all the organisms associated with spontaneous remission by establishing a center for data collection. But that didn't quite work out. So I had to come up with a mechanism in a laboratory whereby I could isolate organisms with specific appetites and high affinity for cancer, organisms that would stick to the cancer, have anti-cancer effects, and mark the cancer so it would look like the organism itself. And the laboratory technique was simple. You basically put a whole lot of bottles on your bench, put biopsies of cancer, of the same cancer, into the various bottles, and add cultures of organisms to each bottle, and then wait and see which organism grows and attacks or attaches to the cancer. And we see here that in these three bottles very little is happening, but in this fourth one something appears to be happening. In close-up, we see the biopsy, and this cancer is a lymphoma. In this culture, is totally unaffected. It remains the same. However, in this bottle, the culture seems to be exuding a protein-like filament, filaments of protein or some substance, which are reaching out and engulfing the cancer. And if we close up on that, we see here's the ball of cancer, and here are these filaments, organism filaments, which are reaching out, encapsulating it, and penetrating its outer layers. Some researchers have said that the cancer's ability to repel and resist the immune response lies in its outer layers. We see here that this tagging of the cancer by microbial components is a way to totally bypass the resistance mechanism and destroy the resistance mechanism. Given time, the organism actually blossoms into a mushroom, and you see very little of the cancer remaining here. It's being digested by the organism. And at the end of 6 weeks, all you see left is a mushroom. The cancer is totally demolished and removed. The beautiful thing about this technology is that not only does it identify organisms with affinity for cancer, not only can it be used to create organisms with affinity for cancer, it also leaves you with liquids which are full of anti-cancer chemicals, biologicals, and enzymes. These organisms don't just kill cancer, they also digest it and totally metabolize it. In other words, they don't just destroy the disease, they also clean up after themselves. And all of these are compounds which can be used in therapy. Now we come to this. This is a slide of acid-fast bacilli. And we come to a problem. When I would totally destroy the cancer by this mechanism, or by several other mechanisms, if destruction of cancer took place in a laboratory setting, and I then cultured the destroyed tissue, I would often see organisms. And the organisms could be acid-fast bacilli, such as are seen here, and such as have been reported in association with lymphoma for many, many years, and with other cancers as well. Or I would see mixtures of staphylococci and streptococci. These are not organisms that I was putting into my culture media. These would come when I would destroy the cancer cell mass. And here they are again. Various types, similar groups, but various different forms of organisms would present themselves. Often linked together, often appearing to be pleomorphing or changing from dots, cocci, to rod forms, as you see the starburst effect here. Now, if we go back for a moment, these slides represent something that's been seen over the past 2 centuries. Cancer researchers have often seen bacteria being grown from cancer. But in recent times, it's been explained away as either contamination or superadded infection. 200 years ago, they thought that they'd isolated the cause of cancer, that it was a bacteria. But if you remember, cancer is a response to several organisms. So nobody was ever able to demonstrate that one bacteria caused cancer. Therefore, that theory was rejected. And today, all the conventional people believe that these bacteria are just contaminants. And yet, if they were, then the work that's about to be shown, which is the work of Dr. Alan Cantwell, and others have also done his work, including myself, but never have been able to capture it or demonstrate it as beautifully as he has. You see here diseased tissue with a nest of organisms. And again, diseased tissue and a well-circumscribed nest of organisms in the heart of the tissue. And yet again, organisms in the middle of tissue. Notice the total lack of inflammatory response around the microorganisms, total lack of immunological response. If these organisms were infecting, you would expect to see a degree of necrosis, you would expect to see a degree of inflammation, yet it's not present. In this AIDS biopsy of an AIDS lymph node, you see these organisms literally rising from the diseased tissue. And yet again, especially in this immunocompromised individual, how is it that these organisms are well circumscribed to an area and apparently encapsulated by the AIDS Kaposi's response? Again, organisms well defined and yet not spreading and yet not being attacked by the immune response. The diseased tissue that I'm showing you runs the gamut from scleroderma to AIDS to cancer. This yeast-like organism is present again in an AIDS lymph node biopsy. This yeast-like structure has been reported many times in the literature and actually has a given name, Russell body, named after, surprise, surprise, Dr. Russell. And he described them as being possibly the cause of cancer. They've been lately explained away as just antibody conglomerates, but nobody really knows what they are. They sure look like yeast to me. Again, we see diseased tissue with these well-circumscribed clumps of organisms, nests of organisms. And here again, we see well-circumscribed nests of organisms, surrounded by diseased tissue, but no inflammatory response. It appears that the only reason that these organisms are not multiplying and spreading is that the diseased tissue, whether it be cancerous, as an ordinary cancer, or Kaposi's with AIDS, or scleroderma, collagen vascular diseases, these diseased tissues are being generated to encapsulate and enclose and prevent the spread of these organisms. This is an inflammatory bowel condition in an AIDS patient. Again, you see a well-circumscribed nest of organisms. And even in cases of cardiovascular disease, and this is an AIDS patient with myocardiopathy, you can see well-circumscribed organisms without an immune response. Now, this perhaps is what's important about these organisms and these patients. The relationship here is to develop serious diseases such as collagen vascular diseases, such as AIDS, such as cancer, or to have cancer develop in AIDS patients. These organisms appear able to induce that because they're at a point where, either because of something inherent in them or inherent in the patient, they do not attract a curative immune response out of the patient. The patient is then left with no option but to generate a disease that can encapsulate and enclose them. Here, in breast cancer, you see a perfectly circumscribed nest of organisms. Again, breast cancer cells, fat cells, but no immune response anywhere to be seen. It's interesting to note that some of these organisms have been isolated out of overweight people, and that it is possible that people who sincerely have a problem losing weight may do so because fat is being used as an enclosing mechanism for these organisms. There have been patients who have been overweight with cancer where I have vaccinated them against the organism only to notice a drastic reduction in the total body fat, which went concurrently with loss of cancer mass. I don't believe the same cause of overweightness is the cause of cancer. It's just an interesting phenomenon to observe that the restrictive immunological response that I have described for cancer may be generated by collagen vascular diseases, may be generated by multiple of diseases, may be even generated by normal body structures such as fat cells. To restrict the disease and stop it from spreading. So, if we now consider the therapy of such a patient, patient presents to the doctor, we biopsy the cancer, and we see these organisms. We then need to raise a vaccine against these organisms. Now, induced remission therapy in practice is a little bit simpler than that because other body tissues can be used to isolate the causative organisms or the disease-associated organism. But in this case, let us say we took a biopsy of the cancer. Here is the organism. We culture the organism. We then raise a vaccine against it. So instead of vaccinating against cancer, we're now vaccinating against the organism. We have got a new target. These organisms can also be treated by antibiotics. And it's been long known that antibiotics in combination may sometimes cause at least a transient remission in cancer patients. This is the reason. Cancer itself is just an immune response to enclose the causative factors. If we culture these, kill them, and vaccinate the patient against them so he can mount an immune response against them, we tend to find that cancer masses, this is a breast cancer mass, patient is vaccinated against the organism related. You see the breast cancer here is reaching up to the skin and back towards the muscles of the chest. This would not be an easy operation. It would be quite unsightly and disfiguring. But after vaccination, you see that the cancer mass has pulled right back away from the deeper structures and back away from the skin. This could be easily resected, and it's at least 30% smaller only 3 weeks after the vaccination program was commenced. Again, we see a breast cancer mass here. It's a mammogram like the previous one. And 4 weeks after treatment, you see it flattened out to virtually nothing. Again, all we're doing here is not chemotherapy, not radiotherapy, not hormone therapy, not surgery. What we're doing is taking the organism that we isolated and vaccinating against it. And here you see a huge cancer mass which is ulcerated. Again, a mammogram. And 2 weeks after vaccination, you see it down to less than half the size. Purely by attacking the organism rather than the response to the organism. Purely by attacking the bacteria rather than the cancer. Now in this next case, we see small cell carcinoma of the lung, which can be seen as a small triangular area here, which is actually affecting the lymph nodes in the chest. And we see that after vaccination against the organism that's associated, within 2 months, the cancer itself has disappeared, and the lymph node mass has resolved to normal lymph node size. So what we've done in the prior cases, in the previous cases, we've isolated the organism that I believe was related to the cause of the cancer, and we vaccinate against it. This can be done autogenously, which means we actually take the biopsy from the patient or patient blood to isolate the organism and vaccinate against it. And autogenous vaccines, to the best of my knowledge, in the United States and in many parts of the world are legal if done in recognized establishments. Now, we can also have the option of using passive vaccines, which means if the body cannot generate a good enough response against the cancer, or the cancer organism rather, we then take the organism, inject it into a horse or whatever other animal, isolate an anti-serum, purify that so it doesn't give the patient any allergies, and use that to treat the patient with. Now, the use of passive vaccines in AIDS more than anything is a critically needed therapy at this moment in time. I find that it's almost insane that this technology hasn't been applied. The problems of people saying, well, the AIDS virus keeps mutating, so we can't make a vaccine against it, tend to melt away when you realize that your vaccine factory in passive vaccines is a living horse or another living animal, and that each time the virus mutates, you can develop a new vaccine for it in 2 weeks. Now, there's much more complex technology than that involved, but even use of plain old horse serum with its resistance to AIDS, to the AIDS virus, vaccinate a horse, although it would be preferable to get a higher level, you can just use ordinary horse serum purified against the patient's virus. There's something important to mention at this juncture. Whether or not this is believable, whether or not the doctors out there listening find it possible to accept that horses can develop a good immune response against AIDS, the pure fact of the matter is that the infections that often follow AIDS can be easily prevented by horse sera passive vaccination, and that we do have precedents in seeing that horse sera is useful in the treatment of bacterial and viral infections from 100 years ago. True, 100 years ago, horse sera gave certain allergies. Today we can purify those allergies away, most of them, if not all. And the other advantages are that when you're targeting the real cause of AIDS, of cancer, you can actually raise a system that supports yours. So that if your immune response is not strong enough to cope, regardless how well it's stimulated, use an animal's immune response. The inherent resistance of virtually every animal other than a human to HIV tends to indicate you could use extracts of virtually other animal other than HIV in the curative process, in the therapeutics. Recently, headlines all around the world were that an AIDS patient received a baboon bone marrow transplant with the reasoning that baboons have resistance to the AIDS virus, and therefore the bone marrow would not be affected by the HIV? Well, that indicates at least that people are thinking along the same lines as I am. The use of antibodies, of course, or serum extract from a horse would probably run you significantly less than the several hundreds of thousands needed to transplant a baboon's bone marrow into a patient. And you wouldn't risk the baboon's bone marrow rejecting your body at some future date. I think there's a much simpler technology at play here and a much more logical one. I think there's a much simpler technology that could be used here, and it's far more logical than the extremes to which that patient has been applied. It's also important to realize that HIV is not the only factor active in AIDS. HIV is perhaps an important factor, perhaps only a marker. There are other things active. There's the infections, the bacterial type organisms that I showed in the slides. There's the fungal type organisms I showed in the slides. There are many of the sequelae of AIDS which cannot be explained as simple immunosuppression. Kaposi sarcoma, pneumocystis, many of these sequences that follow the AIDS process and that are brutally monotonous in expression towards end-stage AIDS must have something to do with the disease process in the first place, because they're rather rare things to happen to an ordinary person. So if it's just an immune response weakening, you'd expect that the complications would be common complications. They're not, they're rare. And it's in my view that rare complications probably exist in the disease process at the onset, probably form a complex of causative factors early in the disease phase, in the disease process. So we can vaccinate against the organisms actively and passively. And if we just use this concept of vaccinating actively against the organisms we've identified, the bacterial type organisms, if we use the process of vaccinating passively against HIV, and if you bear in mind that patients have been treated by this technology for AIDS in countries where it's permitted by law to use alternative technology in compassionate grounds, on compassionate grounds, and people who are terminal, who have no other available options. Cases which have been documented have demonstrated a tenfold decrease in PCR levels, PCR being the viral load measurement in the AIDS patient, in a period of 3 days, to a week to 2 weeks, but a dramatic drop in PCR levels. This is accompanied by an equally dramatic jump in T-cell numbers, T-cells being the markers of the immune system of the AIDS patient. T4 cells, which were down to 100 or 200 points, can often leap to 800 or 900 within a week to 10 days. So this is clear indication of the phenomenal capacity for healing that active vaccination against other causes other than HIV, combined with passive vaccination against them and against the HIV, can give in otherwise hopeless situations and scenarios. Again, bear in mind, we're talking about simple technology. Bear in mind that passive vaccines from horses were applied to thousands, if not hundreds of thousands of recipients over the past century. And bear in mind that there is nothing else capable of coming even close to the types of results that I've mentioned to you. The clinical improvement is very rapid, with noticeable improvement in appetite and in energy levels. But the very dramatic thing is the indisputable changes in T-cell parameters and PCR. And as we speak now, there are several universities investigating these vaccines and these therapies in vitro trials. And there are people receiving it as therapy wherever it's legally available. Now, we need to move on to the slides to demonstrate an important point of passive vaccination against cancer. Now, when we're speaking about passive vaccines for cancer, it is very important that we identify cause from response, whereby the organisms I've spoken about or the other factors that are causative agents are the cause, and the cancer cell is purely the response. Reason is We spoke about AIDS, where we can raise an anti-HIV response passively in a horse and use the horse serum to significantly improve the patients and to cure some. Whereas with cancer, as in this case with leukemia, we see two leukemic cells here and some red blood cells here and some platelet particles. We are now going to raise an anti-serum in a horse against the leukemia cell. We're going to inject the horse with these leukemia cells and hopefully get an anti-serum which is going to destroy leukemia. And that is what happens, but with some rather nasty consequences. The horse's anti-serum destroys everything, not just the leukemia cells, also the red blood cells that were up here. Addition of anti-sera raised in this way to human blood destroys virtually every element of the human blood. In other words, the horse cannot tell the difference between a leukemia cell and a healthy white blood cell, or a leukemia cell and a normal red blood cell. The horse just mounts an anti-human response. It used to be thought that that meant that the horse's immune system could not distinguish between cancer and ordinary cells because the horse's immune system was not good enough. I'm saying the horse's immune system is good enough. There's just very little difference between the two things because the cancer cell is just a normal cell responding to abnormal stimuli. However, if we see in this biopsy of Kaposi's sarcoma from an AIDS patient, this yeast cell, which is fungating, I mean, nothing else can look like this. It's a yeast cell. I shouldn't say fungating, it's budding. It's having little yeast babies. And another two of them up here, 3 even. Again, these have often been described as Russell bodies, but this pretty much looks like a yeast cell having babies. If this is the organism associated with Kaposi's sarcoma, or with this case of Kaposi's sarcoma, and I've isolated similar organisms from leukemia, I'm now going to raise a horse anti-serum against the organism, not against the cancer. The horse has never seen the cancer. The horse has never seen this leukemia cell. All we've done is vaccinate the horse against the organism I just showed you in the previous slide. We will now add the horse's anti-serum to this blood film. And what you find is that within about 20 minutes, the cancer cell begins to fragment with such intensity that it's broken the slide. That was a joke. The audience is asleep. What you see after 30 minutes, the cancer cell cytoplasm and nucleus have been totally destroyed, but most importantly, the red blood cells are still in perfect shape and health, which means that the anti-serum against the cancer organism caused selective destruction of the cancer cell, probably along with the organism, but did not in the least affect the healthy cells. And this is a way of making a specific, highly active vaccine. So by aiming at the organism rather than by aiming at the cancer, we can develop good, safe therapeutic technology. So now, let's see how this looks in the leukemia patient. Here's a patient with lymphocytic leukemia. The patient is, the dark blue cells represent the leukemia cells. The patient is injected with the anti-serum to the organism, and within 2 hours, the patient has less than half the leukemia cells that he had previously, and these cells look pretty much out of it. The cytoplasm is damaged, the nuclear structure is damaged. This is a very, very rapid effect that could not possibly be even approached by current chemotherapeutic or other conventional technology. Now, of vital importance to proving the link between those organisms and cancer cells and disease cells in general, and probably the new area of genetic engineering or the next area to be developed will probably be based on this form of technology, because we see here in the following slide that by raising an anti-serum against the genetic structure of the organisms, we can actually selectively remove from the genetic structure of the leukemia cell. These areas called vacuolations happened after we exposed this leukemia cell to anti-serum against the bacterial genetics or the organism genetics. again without any damaging effect to the surrounding cells. What laboratory studies have shown is that this cell could now well go on to divide into two normal healthy white blood cells. The importance of being able to specifically remove genetics in this form is massive when we consider genetic diseases without any prior form of therapy, where we'll consider the possibility that genetic diseases may be linked to certain organisms and that vaccines against these organisms may be able to correct, if not the genetic structure, at least a large part of the pathology associated with the genetic damage. So we've spoken about and seen results from two parts of the induced remission therapy protocol. One part being selective tagging of cancer. We're using safe bacterial organism structures, extracts, non-living bacteria. And we've spoken about targeting the cancer by the organisms which may be its causative agent in the first place. We've spoken about throwing passive vaccines against the organisms we can isolate from cancer biopsies and from cancer patients so that we can eliminate the disease entirely. And yet, application of tagging and targeting technology did not resolve the disease totally, in that we did achieve several remissions, we did achieve several massive regressions, but the cancer tended to return, and there was a point where the vaccines appeared to stop working. Now, this goes back to what we discussed a long time back in the video, the process of anticipation. Process of anticipation applies just as much to vaccines as it does to chemotherapy, radiotherapy, or whatever. If I vaccinate a patient, I will destroy all the cells sensitive to the vaccine. What I will be left with is cells which aren't sensitive to the vaccine. If I anticipate the resistant cells and develop vaccines against them too, and apply them at the onset, I get much more marked and dramatic responses. In that, the body will be ready for the changes as they arise. The process of anticipation can be seen here in combination with virtually any form of therapy as being effective. In this particular slide, patient with breast cancer, seen here on mammogram, presented to me, and she was about to have tamoxifen, which is a hormone which is known to shrink cancer cells. We cultured the cells in the laboratory to find which cells would escape the effects of tamoxifen. We then vaccinated against those cells. And then after the vaccination, 2 weeks later, we initiated therapy with tamoxifen. The shrinkage from this to that shows changes over a 1 month period, virtual disappearance of the massive density and massive shrinkage. Now, of course, you could say, well, maybe that would have happened with the tamoxifen anyway, but this is but one example of anticipating a change with vaccines, and there are many others which have demonstrated marked continued shrinkage, far beyond expect to happen with simple hormone therapy, and far beyond that you would expect to be sustained with simple hormonal therapy. Much more dramatically, however, is taking a case which is undoubtedly more difficult, where a patient has a breast cancer that has spread to the liver, and you can see here the breast cancer mass. This is a cyst that the patient was born with. The patient was about to undergo adriamycin chemotherapy. Treated with adriamycin, we saw to find the cells that were resistant to the chemotherapy. The patient was then vaccinated against those cells in anticipation of their evolution. 2 weeks after the vaccine, adriamycin was administered, and within days, the cancer was totally dissolved. And you know it's the same patient because you can still see her cyst up here. So now we have all three parts of induced remission. The tagging and targeting, we have the use of resistant immune systems, and we have the anticipation of changes. And let's see cases where patients have presented And although we're concentrating on cancer and AIDS throughout this video, you need to understand that this therapy applies to arthritis, to lupus, multiple sclerosis, virtually any disease where we can remove isolated organisms, where we can isolate organisms which may be culpable or which may be associated with aggravating the disease process. We then target these organisms actively and passively by raising vaccines, and we anticipate the changes and prevent the changes from arising by vaccinating against them. This patient presented with a hepatoma which had perforated his, and the cancer is now totally surrounding his right lung. The organism was isolated, patient was vaccinated against it, it was killed and introduced him as a vaccine, autogenous vaccine. We also had a passive vaccine raised against it, and we anticipated the changes it would have to the vaccine, so we used vaccines which also took into account changes that the cancer may go into. Here's the cancer again totally surrounding the right lung, and after 6 weeks of therapy, the cancer has totally resolved from the lung, although it's still present here in the liver. Patient with prostate cancer in the left lung, metastasized to the left lung, it's a CAT scan. And after 5 weeks of therapy, the cancer is totally removed, totally gone. Again, we're not vaccinating against just the cancer cells, we're vaccinating against the cause or against the associated organism. That's the key feature. Bone cancer from the prostate. All these lesions represent bone secondaries from the prostate primary. And after 3 weeks of treatment, the ribs are totally clear. Lymphoma, non-Hodgkin's giant cell. All this area here represents a huge lymphoma which was pressing on this lady's heart, 32-year-old woman. She was given only a week or two to live. Isolate the organism, we vaccinate against it, and after only a week of therapy, the cancer is virtually totally resolved. The precise measurements are that it had gone down from 15.5 centimeters down to 3 centimeters within 7 days. Squamous cell carcinoma, smoker's lung cancer. You see it here extending all the way. You see all those fine to the apex of the lung. And after only 2 weeks of therapy, shrunk down to a scar. Brain cancer here. It's a secondary from small cell carcinoma. And here. And after 2 months of treatment, you see that this one is still here but markedly shrunk. But that this one has totally resolved. Cancer of the esophagus is perhaps the most difficult cancer to treat. It's notoriously resistant to radiation and chemotherapy. And you see it here totally obstructing this patient's esophagus. This man cannot swallow, he cannot eat, he cannot drink. This tiny black dot here is the only opening he has in his esophagus. And he can't swallow through that, so they've put a tube into his stomach. He chews his food and spits into the tube to get his nutrition. And here's another picture of the same total obstruction of the esophagus. And yet after only 4 weeks of treatment, you see that the esophagus is totally open and the cancer has markedly shrunk. In fact, there's only thickening of the esophagus wall left. And this is unheard of by any therapy for esophageal cancer. Granulocytic leukemia. All these large blue cells represent leukemia cells. And this is a remarkable case. After only 1 week of therapy, the child was in remission. Breast cancer, adenocarcinoma in a mammogram here. And after only 10 days of treatment, virtual remission. This represents probably one of my best friends. She presented to me with breast cancer, which can be seen here in the wall of the lungs. And all this white mess here is cancer and cancer fluid. And after 5 weeks of therapy, by the way, this is a normal lung. This is what a normal lung should look like. All the white here is the breast cancer and cancer fluid. And after 5 weeks of therapy, the lung is virtually clear of the cancer. This data hasn't just been done on cases that I've presented to you. It's also been confirmed or supported by preliminary investigations in universities such as the University of Colorado and other major institutes. Here we see human melanoma cells in culture. These white circles represent melanoma cells, and this is work from that institute. Now, the important thing about human melanoma cells in culture is that they're notoriously unbeatable. You could use the best chemotherapeutic agent and the best radiotherapy that you can at levels toxic to normal cells and still only kill perhaps 10 to 12% of these cells over a 3-day period. However, the white cells represent living cells, and black cells have taken up the dye in which this slide has been mounted. Black cells demonstrate dead cells. So after exposure to my vaccine, the white cells within 12 hours have all died. We're talking here, I mean, you got to have an appreciation of the importance of this. You are speaking about a 100% kill of an unkillable cancer in a period of time that is ridiculously short. These are human leukemia cells in culture. Again, all white, clear. This is virtually 100% viability. And then within 12 to 15 hours of incubation of the vaccine, they've all taken up the dye, they're all dead. They've all taken up the color in the slide, which means that they're all dead. Again, 100% kill. And yet, the normal human cells tested against these vaccines had a 98 to 99% viability, meaning that virtually no toxicity existed in these trials or in similar trials for these vaccines. So what we've seen here is that with virtually every disease condition, it is possible to isolate organisms which are associated with and which may aggravate the disease process. And it is possible to obtain at least partial, if not complete, healings by addressing those associated organisms in whatever form we've discussed, mainly in vaccination form. Now, vaccines against cancer are nothing new. Use of organisms against cancer is nothing new. I think it's standard protocol now to inject the tuberculosis organism into bladder cancer patients, and it has been generally used in the treatment of melanoma and lung cancer for many years in several parts around the world. There have been the occasional updates on the war of cancer, where some new deadly organism has been found to be capable of shrinking cancer masses. Listeria hit the newspapers in Australia just a short while ago. A vaccine made of listeria was used to attach to and destroy cancer cells. And essentially the main variation, the main difference between that and my technology is that my organisms are safe organisms. I don't use entire organisms, I don't use living organisms, and I match them in the way we've seen. In cancer, a patient can present, a biopsy of the tumor can be analyzed for the organisms, the patient's blood may be analyzed. In virtually all diseases, organisms may be isolated from some sample of the patient and target for vaccine therapy elicited in that manner. You can raise the vaccines actively to try and stimulate the patient's own response to remove the need for the disease, or you can raise passive immune responses against them, against the causative or associated agents. The most important other development in induced remission technology is that you are anticipating changes before they arise and you're neutralizing them before they're ever manifested. You've seen the results, you've seen clinical data, you've seen laboratory data. It is also the latest in scientific technology, Scientific American February edition from 1996, and an article essentially about ulcers and Heliobacter. The research scientist there speaks about the findings of microorganisms in certain types of cancer and how he hopes that one day soon we'll be able to use antibiotics and other therapies to eliminate the organisms and then subsequently eliminate the cancer. Well, this isn't future technology. The technology is here, the technology is now, and it's been shown to you. I've invited several of the leading cancer and other research institutes to investigate this therapy, and some such investigation is taking place right now. I'm offering the therapy free to 100 patients and offering $10,000 to wishes to that as a real therapy or as a fallacy. Essentially, I'm doing everything that I can to prove that this works, because my deepest is for everybody to be able to benefit from this technology and from these developments. And I'm not at a point yet where I can cure 100% of cases. I don't have a full library of associated organisms. These are the sorts of data, the sorts of findings that can be elicited only by large groups investigating further into this technology or by time. As it is, the 15 to 20% cure rate, or rather 10 to 15% cure rate across the board for cancer, it's a much higher number cure rate for AIDS and other diseases, and it's an 80% regression rate or remission rate, or rather response rate in otherwise hopeless cases. Less severe diseases such as arthritis or asthma or chronic fatigue, again, everything tends to fall once confronted with this technology, and the less severe diseases tend to respond much faster and to a much higher degree of success. I would like you, when making a life decision, to not let the doctor with a terminal poor prognosis. We have no other options, we have no other choices, I'm sorry. You can't let the doctor that, you can't accept that. At the same time, you can't listen to people who aren't doctors, who are fakes, who are quacks, or are lunatics, who propose that you do any of the myriads of fake quack therapies out there right now. And you have to put some effort into trying to save lives. You have to take information that's out there, present it to the doctors, allow them to tell you why it's good or why it's bad, and challenge them or accept what they say, but confront them with the information. Confront them with hard facts. If any therapy out there can present you with before and after x-rays like you've seen today, confront your oncologist with that. Do not accept a terminal prognosis as being final. I like to say one sentence which captivates or best expresses my thoughts, and that is related to 12 years, or actually it's coming up to 16 years now, of battling to get this therapy and this technology out to the public. I initially started from within, approaching my peers, and for many years everything fell on deaf ears. And now it is time. I give it away in a simple way to the public. I redouble efforts with the medical community. But now it is time for people whose lives are endangered and for people whose relatives or whose loved ones are in danger to also start taking some responsibility and to also start supporting some life-saving technology such as this. What I like to say is that in this, what I call the Kevorkian age, where people champion the right to die with dignity, confronted with suffering and pain, that equal effort be put into championing a technology that can remove the suffering and pain and restore the option of life.
Within this presentation, the term cure is used to refer to the disappearance of disease and disease manifestation for a prolonged period of time. When the term remission is used, this refers to stabilization or repression of disease, but not to the total disappearance of disease. The statistics presented refer to studies over several months or years. Statistics on the most